Good morning, good noon, good afternoon, everybody. Happy Friday. It is RLR version 1 bajillion million. Yes, Prophet is working hard all day long and getting his day started with us. For those of you who are curious why I said that, that's why you should work hard and be part of the academy. Present some cases, hang out with us, and you'll get to know the intimate secrets of
Don't get me
Prophet.
fired, Robbie. This is being recorded. No, I'm just kidding.
I didn't say anything. I said you're working hard all day long, man. But today is an all internal affair. We are very lucky to have our team members both scribing and presenting today. Starting off with Lyra, who is scribing. So, Lyra, do you want to unmute, tell people a little bit about yourself and what you're up to today?
Yeah, hi everyone. My name is Lyra. I'm a final year medical student. Just started my new rotation. It's forensic pathology rotation. Very interesting, yeah.
Whoa. Oh my God. Okay, I have to contain myself and control myself because I will have 100 follow-up questions, but I'm going to ask them later. That sounds really interesting, Lyra. All right, we'll have to explore that later. Rahul is doing teaching points. Rahul, what's new with you?
Hi, Rabi. Hi, Reza. I'm honestly nothing, Rabi. I mean, spending time with my family, some reading about the PBC again, the studies discussion, and yeah, doing some workout. Yeah, that's it.
Hey, the simple life is the best life. Just ask Prof. Rez and I. We do basically the same thing all day, every day, huh, Prof. Rez?
We do, Rahul. I'm right there with you. I loved your energy and your directness with Robbie in terms of your response. Keep that up, please. It's like, yo, Robbie, how are you? I'm good, not bad.
What's new? Oh, that's okay. Manahil, you're presenting first time on RLR.
Yeah, hi everyone. I'm Minal. I am Chief from Pakistan and very much excited for today's case.
I'm very excited to have you. Tell us what's new in your life.
So for me, like I went for lunch with my mat school friends today. So it was a meetup,
Yeah, that's so nice. How was it to see them?
very nice.
Yeah.
Like we were
Oh,
meeting after like a year.
wow, incredible. Yeah, I love reunion. I'm not a very, as Prof. Rez knows, I'm not an extremely social person, but there's something special about reunions. And Prof. Rez and I had a reunion with our program directors. It's one of the very few social things that I went to. And I lasted how long, Prof. Rez? 30 minutes, 35 minutes?
He was so strategic. He just kept working his way back towards the exit and talking. And then before I look around and he's not even there.
But I love hanging out and socializing with you guys. And so, Manahil, I know you have there's a little bit of a backstory to the case today. So if you want to share that, and then we can jump right into to hear
Yeah,
more.
sure. Okay, so the case I'm presenting today, I have not seen the patient myself. This is the case shared by our CP Solar member, Alec. So I am presenting on his behalf. Okay, so the chief complaint. So this is a story of a 61-year-old woman who presented to the ED with altered mental status and hyperglycemia. Moving towards the history of present illness, the patient was brought to the ED after her friend noticed confusion and difficulty speaking. Initially, the patient was treated as a potential cord stroke, but a thorough neurological exam showed no deficit, and non-contrast head CT and CTA of the head and neck were negative for the acute ischemia or any other vascular pathology. Then we give the patient some intravascular fluid. She was back to her neurologic baseline after that. So in history, she reported that she have a 1 week history of abdominal pain, nausea, and vomiting. Episodes of vomiting she described as brown in color. She also endorsed fatigue, decreased oral intake. She has been unable to tolerate the medications or solid food. She was just drinking a small amount of liquid and had persistent acid reflux, for which she had tried some over-the-counter remedies, but with minimal relief. And she denied the fever, chill, hematemesis, melena, or sick contact. She also denied chest pain, shortness of breath. So that's the end of first aliquot.
Thank you so much. There's so much to unpack here. And we can speculate in so many ways, but I'm going to try to be as authentic as possible, as if I were in Dr. Ramzan's shoe taking care of this patient. And right away, with the chief concern of altered mental status and hyperglycemia, the mistake here would be to be reflexive and say, oh, the hyperglycemia is causing the altered mental status. That is a feasible connection, but it may lead to premature closure and anchoring on the wrong problem. And I think the best way to demonstrate this, Robbie, actually, is the figure you have of ABC. I don't know how accessible it is on your computer, if you can pull that up, because to me, that like was a game changer in how I approach connecting possible symptoms to one another versus looking for an underlying etiology. Maybe while you're pulling that up, and if you're ready, I would love for my teaching to be you teaching us that figure, and then whatever else you want to add on.
No, Prof. Rez, you should go for it, my friend. Here it is. Go for it.
All right. Thank you so much, Robbie. And the reason so we have, let's say A is altered mental status and B is hyperglycemia. One easy way to connect the two is say someone's hyperglycemic, right? Glucose, when you get to really high levels, it's no longer going into the cell. And so all of a sudden, you're going to have a shift in fluid. And when you have that shift in fluid, it may have an impact on your brain parenchyma and your neurons from firing. And that's why patients with severe hyperglycemia can present with coma because of the shift in water. So that's a direct link. But now let's look at it the other way around. Could altered mental status lead to hyperglycemia? So can A cause B? Think about this. A patient is altered for another reason. They have a background of diabetes and they're no longer taking their insulin. What happens to the glucose? It goes up, right? So you can easily see how someone who's confused, having abdominal pain, doesn't take their insulin, develops hyperglycemia. But you can also see how if someone has uncontrolled diabetes to the point that they get so hyperglycemic that it's causing cerebral edema, now they have altered mental status. And so then the question becomes, how about if both are true, but there is an underlying driver for both the altered mental status and the hyperglycemia, meaning that there's some kind of trigger that's causing stress hormones to be elevated, catecholamines to be elevated, leading to the hyperglycemia, and that same trigger is causing the altered mental status. So I think in a case like this, you have to be calm and collected in your approach, and you have to apply the law of proportionality. So if the glucose was just 250 or 300, neither of us would say this is causing the altered mental status. But if that glucose is 1,000 or 1,200, then all of a sudden we're like, okay, this is definitely causing the altered mental status. Let's now figure out what's driving the hyperglycemia. So the magnitude matters more so than it being positive or negative. The other thing that's, I think, really helpful here, Robbie, is just how transient this episode was, meaning that the patient comes in altered, is hyperglycemic, gets some fluid, and is better. So whatever that insult was, it seems that it was transient in terms of the confusion, but it's easy to see how someone can be hypovolemic from vomiting and having abdominal pain. What I'm trying to really hammer in there is I'm not sure what problem I'm solving yet. I don't know what's a consequence and what is the signal and the actual trigger. I would love to hear from you, my friend, the creator of that phenomenal figure.
Oh, Prof. Rez, I have nothing to add to that. And I completely agree with you. And I'm just now in a space where wondering about other circumstances I've been where something got better, but I still had to pay attention to it. And I think right now, the question that I'm wondering is, should we just go and focus on the abdomen, since that seems to be where the action is right this moment, and the brain has fixed itself? Or is there a reason to actually say, oh, it's fixed itself, but it's going to come back? And I think that's the dilemma that I'm having. And I wish I could know more about what the difficulty speaking is, because as you've taught us, difficulty speaking is either an issue with the software, meaning that you are having a hard time knowing what to say, versus a difficulty with the hardware knowing how to say it. So a difficulty knowing what to say, aphasia, is very much an intrinsic brain problem in most instances, versus difficulty in how you pronounce something or say something, dysarthria, is very frequently a toxic metabolic thing. So if you tell me that in retrospect, actually, this is confusion and aphasia, I would be like, did she seize? And now she's going to seize again? But if you tell me that this is confusion and dysarthria, which is a problem with how to say things, then I would say, you know, I think that confusion and dysarthria are both diffuse diseases affecting most of the brain. So the probability of an intrinsic focal lesion is pretty low. So I think I'm right there with you. I don't know where the disease lives. And I also don't know if the brain is going to come up and tap us on the back and say, hey, look at me again, or we're never going to hear more about it. But I think it's important to not have your back fully turned to it, but to keep one eye on it in case it comes back, and in case it becomes part of the problem. So that's the tension that I'm living. But I'm curious, Manahel, what how this case tumbles and where we go next.
So wonderful discussion. Moving to the allocate 2. So in past medical history, patient have type 2 diabetes mellitus that is complicated by neuropathy, hypertension, hyperlipidemia since 2018. Past surgical history is non-significant. In family history, her mother is diabetic and also have a stroke. Father is hypertensive. Maternal grandfather had gastric cancer. Social history, he never smoked, never used tobacco, non-alcohol use, no substance use, no recent travel or sick contact. In her medication, she take atorvastatin 40 milligram daily, lisinopril 2.5 mg daily, metformin 250 mg BD, then glibenclamide 2.5 mg BD. And she is allergic to losartan. She developed hyperkalemia after taking it. So this is the end of the second allocate.
Yeah, just to share some brief reflections here, and I think that the only thing that caught my eye really is the medication list, and I think that the reason the medication list is important to pay attention to is the simplest and easiest way that a patient can have a systemic syndrome is to have something that is a molecule that mediates the symptoms from head to toe. So this is why in patients who have anemia, they have fatigue, malaise, shortness of breath, cramping in their legs, head to toe. And so as you're thinking about how the background can help you prioritize a systemic issue, it's really looking very closely at the med list, which can diffuse throughout the body and cause systemic symptoms. And so I think it's really important to really realize that the sulfonylureas have very, very adverse, high risk of adverse side effects, especially hypoglycemia, which is not the case in this patient. We know she's hyperglycemic. But anytime that your patient is at risk of kidney dysfunction, as this patient is by virtue of her nausea and vomiting, you have to pay attention to the metformin, because metformin can build up and cause a variety of consequences. So I think as we move forward, Manahil already laid out the patient's vulnerability to hyperglycemia by virtue of her diabetes. And now we know this hyperglycemia is not acute, it's acute on chronic. And we, in the face of a systemic syndrome, just have to pay very close attention to her medication list. If she has a CK elevation with rhabdo as her presentation, we'll have to look at the statin. And if she has a disproportionate NN-GAP metabolic acidosis, we'll have to pay attention to the metformin. But these are things that in real life, you're like, noted. And most of the time, you'll end up just deleting them from your working memory. But I think that's the significance that they have for me. Anything to layer on, Professor?
Dude, I love that word diffuse, like the molecule having a diffuse impact. Beautiful, man.
Okay, so shall I move towards the vital sign?
Yes, please. Thank you.
Okay, so her BP was 110/57, pulse was 95, temperature was 36.7, respiratory rate was 25. On general physical examination, she appeared ill, obese, and in acute distress. Mucous membranes were dry, there were no congestion or rhinorrhea. In rate and rhythm was regular, no murmur, no gallops. Pulmonary, no respiratory distress, clear breath sounds. In abdomen, that was like distended and soft with mild tenderness diffusely. And it's like a big verse in the epigastrium, and there was no guarding. Neurologically, she is like alert, oriented to place, person, and time, no focal deficit, strength and sensation grossly intact throughout. So this is the end of third aliquot.
Thank you, Minayo. And I'm going to assume that the oxygen saturation was normal in this patient. Is that a fair assumption?
Yeah.
Okay, thank you. Maybe I'll just talk about the vitals and leave the rest of the exam for Robbie to tackle. I think, vitals are definitely vital. And we've had a recent RLR where it was like really interesting how a particular finding was, overlooked for good reasons. When you look at these vital signs, you see a very fast respiratory rate, but a normal oxygenation. So what I challenge you to do, if you're watching this, hey, YouTube folks, I want to be friends with you, okay? This is me, a guy showing love to you, whoever you are. I want to give you an exercise where you can pause it and say, hey, Prof. Rez really cared about us. It's ignoring the live audience, is just focused on you. Robbie, we're going to befriend them, I promise you. The exercise I want to give you is what is your DDX for tachypnea, but normal oxygenation? If you think about it, almost always the respiratory rate is 16 in the hospital because that's what people document. It's only when you have a significant deviation from that 16 where you have to pause. 25 is a significant deviation, so I can confidently say that this patient is tachypnic. And probably the easiest way to reconcile tachypnea or rapid breathing is that someone is hypoxemic or is short of breath, and so they're breathing quicker. But this patient is not hypoxemic. So a prototypical example of why someone would be breathing fast but having a normal oxygenation is that they have acid buildup, right? Because what do the lungs do when your pH drops? What should they do? That's when we do Winter's formula to see what the PCO2 should be. The PCO2 should be low, so you start breathing fast. And so tachypnea with a normal oxygenation, you have to entertain the possibility that, hey, does this patient have a severe metabolic acidosis? Now, that's not the only cause of tachypnea with the normal oxygenation, because at the end of the day, tachypnea is just the brainstem, the medulla stimulating the respiratory rate. And I can do that voluntarily if I'm anxious, if I'm in pain. I may be shallow breathing, but breathing faster. Or what if there's something happening below the respiratory apparatus and I can't take deep breaths? So to compensate for the lack of volume, I have to take low and shallow breaths. I haven't really formalized, Robbie, a schema for tachypnea with normal oxygenation, but my first reflexive thought is make sure it's not something like metabolic acidosis. Then my second thought is make sure that there's nothing obstructing the respiratory pathway leading to more shallow breaths. And then my third thought is someone is anxious, having a panic attack, or in discomfort. Yeah, I'll pass the mic to you to layer on that and tackle the rest of that.
Yeah, beautiful process, Prof. I'm right there with you. And I think the question is, what else do we find on exam? And I think we find that she is, in fact, dehydrated, as evidenced by the borderline tachycardia, supported by the dry mucous membranes. And I think the question, as you said, is where does the disease live? And I think because you're not hypoxemic with that tachypnea, it's probably not in the lungs, and it seems like it might be in the belly. And the question you might ask is, well, what progress can you make based on the belly exam? And I think the fact that it is diffusely tender is very, very powerful and very helpful. Because if you ask yourself, okay, this is everywhere in the belly, what structures are found everywhere in the belly? And there really is only a few. The most important is the bowel. And so you have to ask yourself, what are the things that I really need to worry about in the bowel acutely? And that's, of course, obstruction. And here, with that thought in mind, distension is a really, really important finding that Manahil shared with us. But of course, bowel obstruction isn't the only serious bowel disease. It's perforation, ischemia, and inflammation. And so here, I think that the fact that she's diffusely tender and distended would have me worry enough about the bowel and worry that she might have a bowel obstruction. But immediately as I think that, I'm like, oh, I don't think that that's very probable because she's never had any surgeries in the past. And so the most common cause of bowel obstruction would diminish significantly, but this would push me really, really to try to do a very good pelvic exam, not for gynecological causes of diffuse abdominal tenderness, but to look for inguinal or femoral or obturator hernias, which can present in a very sneaky way. So right now, the focus is on the bowel as the only important structure acutely that causes diffuse abdominal pain, and wondering, is the bowel distended? Is the bowel obstructed? The clue there is distension. Is it ischemic? Is it perforated? Or is it diffusely inflamed? And as a thought exercise, if the bowel hypothesis does not rise to the top of our differential diagnosis, you might ask yourself, okay, well, what else is present in the bowel, in the abdomen, diffusely? And we can touch on that if that becomes relevant later. I wouldn't be thinking about it now in real life because the patient's too sick. She just came back from a code stroke. She's dehydrated. So we should really only focus on the serious causes of abdominal pain, of which, again, obstruction, ischemia, perforation, and diffuse inflammation of the bowel are priorities. So if I were seeing this patient, I think I would say, I'm sorry, but I think we have to go back to where you just came from, the CT scanner. The only thing that would stop me from doing that is EKG, make sure she doesn't have acute myocardial ischemia. And if that's not present, I think the CT scan will be very, very illuminating, either because it tells us the answer or it tells us that there's diffuse abdominal disease without bowel involvement, which would trigger a separate, uncommon, but important to know space that I would then jump into only after that CT scan. So yeah, I'm worried about this patient, Prof. Has code stroke, tachypnic, soft blood pressures, abdominal pain. We gotta move quick. So I'll hand the mic to Manahil to tell us more.
Okay, so moving towards the lab, her WBCs were 10.1 and neutrophils were predominant. Hemoglobin was 13.5, MCV 85.3, platelets were 234. Moving towards the electrolytes, sodium was 112, potassium was 4.8, chloride was like 65, and bicarbonates were low at 17, B1 was high, 109, PRET was 3.3, her baseline was 0.5, glucose were 554, calcium was 7.7, and anion cap was elevated at 3030. So moving towards the LFTs, her AST was 23, ALT was 14, alkaline phosphate was 80, total bilirubin was 1.7, direct bilirubin was 0.2. Her lipase was 99, blood culture and urine culture were negative. Flu, COVID, RSV panel was negative, HIV negative. In venous blood gases, her pH was 7.40, PCO2 was 40.9, bicarbonate was 24.7, lactic acid was 6.2, beta hydroxybutyrate was elevated at 1.6, serum osmolality was 301, and HbA1c was 8%. So I will leave the mic to you guys.
Yeah, Manahil, there's a lot to discuss here. Maybe I can just take a moment for everybody to absorb the data and ask you just to emphasize a couple of them. So correct me if I'm wrong. So the sodium is 112, I remember the creatinine is very high, but I actually forgot the number. Do you mind saying that one more time?
Yeah, so Pret was like 3.3 and her baseline was 0.5.
0.5. Okay. And can you mention the pH and PCO2 one more time, please?
So pH was 7.40
Mm-hmm.
and PCO2 was 40.9.
Okay. Alrighty. Yeah, Professor, maybe I can just tackle the sodium and the creatinine and then hand the mic to you to put it together. I think whenever you see a sodium like this, you should really worry because the possibility of symptomatic hyponatremia looms large. But I think the tension with hyponatremia is the same tension that Prof. Rez emphasized with hyperglycemia. Is it the cause of altered mental status or the cause of a syndrome, or is it a consequence? And in most instances, it's the consequence. And I think you see that the most common cause of hyponatremia is likely at play, and that the patient is markedly hypovolemic. And so you might ask, well, how would somebody be hypovolemic and hyponatremic? Why aren't they hypernatremic? And so that tells you that this patient's actually been dehydrated quite a bit, but she's been compensating by drinking hypotonic fluid. So she's been probably drinking a lot of water to try to overcome this nausea and vomiting that she has, or not eating enough. Either way, her intake, what she is putting in her body is very dilute compared to what's in her blood. And so I think that gives me a sense of how long she's been confused for. I can't imagine her being confused for too long, because she's been compensating by hydrating herself. Unfortunately, hydrating herself much more than her body is able to tolerate. I should say though, I skipped over one simple thing, which is to emphasize that the sodium of 112 is not as bad as it is here because you have to correct it for the glucose, but it's still pretty significantly hyponatremic. And so for me, I think whenever you have a AKI in a patient like this, you really don't have to think too much. Before you start to think about intrinsic renal disease, pre-renal and post-renal diseases are much more common. And in a woman, post-renal disease is pretty rare because of the absence of BPH as a possible cause. So for me, what I would be doing is I would be giving this person a lot of fluid. And I think the question is, well, what fluid would you give her? And in this instance, I think that the amount of fluid she's likely going to need is a decent amount of fluid. And so I would try to mitigate or avoid the risk of using too much sodium chloride. First, to avoid the AKI associated with it, but also to avoid the adding another acid-base problem, which is adding a non-gap metabolic acidosis. So long story short, whenever you have to give a patient more than 1 or 2 liters, you should probably use a more isotonic solution like a lactated Ringer's, which is probably what I would do for this patient. You might say, wait, hold on, don't give her too much fluid. What about her sodium being 112? What if it rapidly corrects? The short answer is I don't think you should care anymore. The idea of osmotic demyelination syndrome being linked to rapid correction of hyponatremia has been largely debunked. The main predictive variables of getting osmotic demyelination syndrome have to do with things beyond your control, especially the patient's nutritional status. So if you look at the patients who get osmotic demyelination syndrome, they are patients with chronic malnutrition from alcohol use or chronic malnutrition from cancer. And we don't know really what drives the osmotic demyelination in them, but it's not rapid correction of hyponatremia. So no longer do you have to sit there and crunch numbers and math, just rehydrate the patient to euvolemia. So these labs that we're seeing in the renal panel are all markers of her dehydration, and they don't have specificity to the cause of her dehydration. And so we really have to replete her. Since we're giving her a fair amount of fluid, I would give her lactated Ringer's. But I wouldn't slow down simply because she's deeply hyponatremic. The link with osmotic demyelination syndrome is not as robust as we thought it was. Rafrez, where are you at?
All right, Robbie. I definitely don't have an answer to this case yet. Let me just preface my discussion with that. And because I am trying to extend a warm hand to the YouTube audience, I have another exercise for them. We're going to be friends by the end of this YouTube challenge and such. My exercise to you is this. Interpret the acid-base disorders or labeled acid-base disorders in this patient. Can you have an acid-base disorder with a normal pH? The pH is fine. It's 7.4. You'll see pulmonologists, some request an ABG for an acid-base disorder, but I don't think that's necessary. I think many would agree with me that a VBG is just fine. So go through that exercise. But practically speaking, Robbie, I quickly look at the meds because all of a sudden we have renal insufficiency. And this is one time I'll stop the metformin. Our old practice was always to stop the metformin in hospitalized patients, but we no longer do that. We only do it in patients who have an AKI and they're at risk of lactic acidosis. And if you think about it, Robbie, that creatinine of 3, we can't really estimate the GFR, not because the calculator isn't working. That's just a snapshot. What if the next creatinine is 7? So you almost have to assume the eGFR is 0 in your mind, though you might have to give meds, antibiotics, and do it based on that eGFR. The glipizide, you got to stop it because you just don't want to muddy the picture. Right now is not a time to do oral diabetic medications. The lisinopril, you got to stop as well. You have a creatinine elevation. The last thing you want to do is give this patient lisinopril. So I'm holding almost all their meds. And then now it's time to interpret the acid-base disorder. The pH is 7.4. So where do we go from there? Where do we go from there? Well, does the body ever create an anion gap acidosis to compensate for something? Does it ever do that? Robbie said it does, but no, it doesn't. I'm just joking. He's just agreeing with my.
Hey!
Don't worry, audience. He always gets me back, and usually I don't understand that he took a strike at me until I re-listened to our episodes because he's just on different wavelength of brain power. But definitely there's an anion gap acidosis. We can all say that confidently. You don't even need a VBG to say that because the body never creates an anion gap acidosis to compensate for metabolic disturbance. Whenever you label it as anion gap, that's a proximal diagnosis. The question is what's driving that anion gap? And I think there's 3 causes here. 2 of them are obvious. One is the lactate that's elevated. Another is the beta-hydroxybutyrate. But then you have to ask the question, why is the beta-hydroxybutyrate elevated? That's again a proximal diagnosis. It's elevated because this patient is not eating. They're vomiting. They are having a lot of stress hormones. They're insulinopemic. They have no insulin. So the beta-hydroxybutyrate is elevated. And it's contributing to the anion gap. The lactic acid is elevated. Most likely it's a type A lactic acidosis where the patient is not perfusing well, despite metformin being on board, and the patient is at risk of type B, where it's not a perfusion issue, but it's more of an issue with aerobic metabolism. So we know that the lactate is probably elevated because of hypoperfusion. And remember, you don't need to be hypotensive to have hypoperfusion. You don't. And once you give the fluid, you're going to recheck that lactate. If it's still elevated despite giving fluid, then you step back and be like, is this the beginning of metformin-induced lactic acidosis? But that's not even the end journey because we still have to understand why is the abdomen distended? Why is this patient vomiting? That could just be a consequence of the milieu that is set up due to the pathology that exists. Whenever you calculate an anion gap acidosis, you have to always do the delta-delta. And a show of hands, maybe you just raise it and I won't be able to see who's so confused about the delta-delta. I know I was confused for a very long time, but let's try to simplify that. If you take this anion gap, which Minahil was nice enough to share with us, was 30, and you assume the patient's normal anion gap is 12 because their albumin is normal, right? And I did the math. So you take 30, you subtract 12 from 30, and I don't want you to laugh at me right now that I'm doing this. You get 18. I'm doing with the calculator so that the Robbie can't make fun of me when I mess up. So think about this. The anion gap, 30, the normal is 12. So that anion gap acidosis is contributing about 18 to the bicarb that you're measuring, 18. So if I take whatever the anion gap is contributing to the bicarb, and I add it to the measured bicarb, here the measured bicarb was 17, right? Plus 17. If it was only an anion gap acidosis, that was a disturbance, when I do the math, I should get a normal bicarb, right? Because I'm accounting for the anion gap by taking the 30 minus 12. I'm accounting for the anion gap. And I'm saying if I add that to the measured bicarb, it should be totally normal if there's no additional metabolic disturbance. But when you do that math, what do you get? You get a bicarb of 35. So this patient has an anion gap acidosis and a metabolic alkalosis. Then the question becomes, why the metabolic alkalosis? They're vomiting. It's not the acid that they're vomiting leading to the metabolic alcohol. You can think of it like that, but it's more the activation of the renin-angiotensin-aldosterone system, where now you're releasing hydrogen ions in the nephron. And that's probably why this patient's bicarb isn't lower than it is. Honestly, like if you have a lactate of 6 and a positive and your bicarb is only 17, you have a metabolic alkalosis. And that's why, my friends, the lungs aren't doing anything. They're like, I'm chilling, because the anion gap and the metabolic alkalosis puts you at a normal pH. I'd love to pass the mic to Robbie just to sort of catch us up to where we are. Like, we're identifying problems, but if you were to, encapsulate this case, Robbie, like, where are we and like, what is next?
I think, Prof, Rez, you're really telling us with your analysis of this that she is vomiting. The compensatory metabolic alkalosis is from her vomiting. Her sodium and her AKI are from her being hypovolemic and hyperhydrating with hypotonic fluids. And so you ask yourself, like, what's going to take you to the path of the answer? The ketones and the glucose are from her not taking her, not having her glucose under control from her diabetes. And so what's the clue towards making progress? And I think it's really the lactate. And I say that because the lactate, under the reason for lactic acidosis is almost always a very specific answer when it's this high, and the patient doesn't have evidence of cardiogenic shock or sepsis physiology. So for me, I feel like now I'm like, okay, well, how do I now put away everything? Analyze lactate. And I think the no miss hypothesis here would be the patient has mesenteric ischemia. She has hypertension, hyperlipidemia, diffuse abdominal pain, and a lactate of 6.2. And that's the no miss diagnosis. But do I ask myself, okay, there's two questions related to that. The first is, do I think that's the likely diagnosis? I think the answer is no, because the syndrome has been going on for a week, and for her to have a week of a mesenteric ischemia that's bad enough to cause a lactate of 6.2, she shouldn't have survived that week. You could have mesenteric ischemia for a week, but not with your lactate at 6.2. Those two things seem to be hard to put together. But I think the real life question that many folks would be facing is, do I get a CTA with contrast in this patient? And I honestly would love to get your take on it, Prof. Rez. I feel like you're the neph guru. So what's your instinct? Do you think you would get that CT now, or is the kidney unhappy with you?
First of all, I just want to thank you for mentioning the possibility of mesenteric ischemia. Even if it's low likelihood, it's a do not miss diagnosis. And I love that, man. And that's one of the reasons I enjoy co-discussing and being on a team, because things that I overlook, someone catches. Things that others overlook, I may catch. And that's I think the power of teamwork. And Robbie, for me, it comes down to the following question. It's not only considering the harm of potential venous contrast-induced nephropathy, it's also considering the harm of not getting that CT scan. You have to weigh both together. It's not just focusing on what you might do, but what you might not diagnose if you don't get the study. And so if you're in a case where you're worried about mesenteric, if that thought came to your head and it's feasible, I'm 100% giving contrast, 100%, because I would be doing an injustice to the patient by not sharing with them the potential harm of not getting that study with contrast. Your thoughts on that, my friend?
Yeah, I completely agree with you, Prof. Rez. I think that at the end of the day, if this is mesenteric ischemia and you don't get the contrast, you don't have a diagnosis. And if you don't have a diagnosis, I guarantee you that unrelenting mesenteric ischemia is far more nephrotoxic than iodinated contrast. So guaranteed. So the question really is, what's your pretest probability of mesenteric ischemia? And I think that's where you have to fine tune your instincts. And I think that in real life, I would probably I would order the scan, and I would tell the tech, please be ready for her in 2 or 3 hours. But let me see what I can do. Because there are alternate causes of lactic acidosis. And if they pan out, I can fix them in the next couple hours. So what would I do in real life? I would give her pressure bags, honestly, of lactated ringers. I would give her some dextrose containing, I would give her some insulin, sorry, and see if I can shut off the ketosis, shut off the lactic acidosis, and wash out other contributors to the lactate, and see 2 hours from now. And if things aren't looking prettier, the tech is already ready for her to diagnose mesenteric ischemia. If the tech isn't, if she doesn't get, if she gets better, then I think we can keep an eye on it. And the only reason I say that is she's kind enough to have given us a whole week of lead time, right? So I think that if she had come in with 1 hour, she's in the CT scanner. But if she has been dealing with this for 1 week, I think we can take a couple hours to try to see how we can address it. But I think there's a lot of variability in how people would do it. But that's how I think I would take it on in the ER. Rahel, what did you and Alec do?
So first, wonderful discussion. I will give some more labs and then we'll move towards the imaging. So urine analysis, we have like specific gravity of 1.018. pH was 5.5. Protein was 1 plus. Glucose 2 plus. Leukocytes were negative. Few bacteria. RBC1, WBC2, trace ketone. Epithelial cells were 11 and hyaline cast was high at 4.29. Urinary chloride was 15. Urinary sodium was 11. Urinary potassium was 48 and urine osmolality was 378. So patient abdominal pain persisted after 2 days of hospitalization despite the normalization of glucose. Sodium and electrolytes improve with resuscitation and replacement. And additional history, the patient noted that she was not passing gas or having bowel movements. So we conducted the X-ray. X-ray showed diffuse significant dilatation of the lobes of small bowel. I have the CT scan imaging to share with you guys, and I have 2 imaging and we'll leave you guys to interpret it.
Robbie, do you mind tackling the imaging, man? You're so expert at all thing bowel obstruction.
You already interpreted it without seeing the image, huh?
Well, you're gonna be able to show them where the lesions are. and
I don't
everything.
know, man. All right, I'll take a crack at the
Remember
image.
that time I was like, what's that black spot in the bone? And it was like unrelated at all to the pathology in the RLR episode.
You know, imaging is really hard. I didn't.
Yeah.
I only, as Prof has know this, but I think the only reason I've had to become better at imaging is because radiology has moved to teleradiology in many instances. So you can't get a wet read easily. So you have to just get better yourself.
I
It's
really can't wait for AI to take over reading imaging, man. Like, we'll still read it, but like for it would be perfect. It would be like better than any radiologist.
100%.
Sorry if there's any, I'm sure there's no radiologist listening to this, but if they are, I said that and I'll say it on record.
There goes your attempt at befriending people on YouTube. Oh, that's so funny. I don't think we can see the image. I think we see a PowerPoint slide, but not.
Okay. Okay, let me share again. Wait. Is it visible now?
Yes, it's visible. Yeah. Alrighty, we can play it. Okay, so there's descended loops of bowel. What I'm looking for is an air fluid level that would be diagnostic of bowel obstruction, and there they are. You see a lot of air fluid levels. What I'm trying to
Robbie,
figure.
can you explain to the audience why the air fluid level is
Yeah, yeah,
diagnostic of bowel obstruction?
Absolutely. Let me just take a quick look. So it's interesting. I think the patient has I can't tell really quickly. I wonder if the patient already has an NG tube in this image. Yeah, Manahal, if you want to just, yeah, why don't you hit play? Yeah, there is an NG tube already. You see in the esophagus, there's a So that's a powerful clue, but and you can already see air fluid levels in the esophagus, right? And as you go into the stomach, there's air fluid levels right there. And I'll explain why, but just to point it out, it's air fluid. And now what you're looking for is to try to figure out like where is the obstruction, and is it small bowel or large bowel is really the most I can do. I'm not an expert at transition points or anything like that. And I think you see that most of the distension is in the center of the abdomen, with the small bowel being mostly located centrally and the large bowel being located peripherally. So yeah, most of it, as you see, like right there is central, and then I'm looking to see at the rectum right there in the middle seems decompressed and not dilated. So I think, so what do air fluid levels signify? Fundamentally, there should be no fluid, and the small bowel secretes a lot of fluid, and that fluid should glide through the intestine. And so whenever there's a lack of good motility of the gut, the fluid gets left behind and gets stuck. And that's what the patient ultimately vomits. You ask yourself, like, what are you vomiting? You're vomiting fluid that you normally should have reabsorbed, but you didn't. And so a PROFRES here, I think it's an interesting analysis, what this EKG represents, because you do see that there is not enough bowel motility. And I think the question is this an obstruction or is this ileus? And that's pretty hard to tell. And the reason ileus should be on our minds is because the patient's diabetic and may have diabetic-related gastrointestinal dysmotility, but also because acute ischemia of the gut results in loss of enteric nervous system function and can present as an ileus marker. And so that's where you have to look very closely at the bowel walls and see, are the bowel walls not contrast enhancing? Are they thick? Is there air in the bowel wall? So I would just emphasize that the picture of acute mesenteric ischemia can really look a lot like bowel obstruction. And that's on my mind for two reasons. The first is, of course, the lactate, but the second is the fact that this patient is presenting with a lot of abdominal pain. Bowel obstruction is a relatively painless condition. Patients present with distension and they're uncomfortable, but they don't usually hurt. And so for me, what I would do is, I've learned based on a case that we had here in VMR and others, that you really have to ask your radiologist to look closely at the mesenteric vessels. And there's data out there that tells us that when we prompt our radiologist to look for mesenteric occlusion, the yield of the CT scan increases dramatically. So I think we have found a diffuse bowel problem on the scan, and I would need a lot of radiology help to help me figure out, is there actually a mechanical obstruction? And if there is, there's our diagnosis, and that has to trigger a second schema. But if there isn't mechanical obstruction, I would really want to make sure that the patient's not ischemic. And I would worry so much about ischemia because of how much pain she seems to be in. What thoughts do you have, Prof. Fred?
Nada, I think that's so clever. Very interested to see how this unfolds, Minahil.
Okay, so I will give the interpretation of the CT. So it showed diffuse small bowel dilatation with a transition point in right lower quadrant, distal ileum, and mild left intrahepatic and extrahepatic pneumobilia with abnormal biliary dilatation. Then patient was placed on angi for bowel decompression. Surgery was consulted. Then diagnostic laparoscopy was performed, and they describe it like there were diffusely dilated lobes of small bowel with simple fluid in the pelvis. Then the loop of the bowel were gently moved to the upper quadrant to examine the area of concern in the right lower quadrant. And there they found a large mass proximal to the ileocecal valve. So right upper quadrant was examined and the gallbladder was noted to be contracted with dense adhesion to the duodenum. So I want to show the picture on what they found on the enterotomy. So like you guys can. Okay. So this is what they found.
Prof, I babbled so much. You're up, my friend.
This is, first of all, Robbie, I just want to rewind back to the first aliquot where we had transient confusion, hyperglycemia, and that abdominal pain. And you so astutely pointed out, like, man, that abdominal pain has been there for 1 week. Maybe that should be our focus of attention. Like, you prioritize that. You didn't neglect or negate the other symptoms, right? And I think once we got to the physical exam, that really, abdominal distension almost always leads to the final answer, abdominal distension. And the question becomes, why is the abdomen distended? And now everything from the metabolic alkalosis, the anion gap acidosis, the hyperglycemia, the lactate, the beta hydroxybutyrate, the vomiting is all due to a small bowel obstruction, all due to that, whatever that surgeon found, that little, what looks like a pigmented stone, maybe. I'm not really sure what that, I would have to ask the surgeon. If they told me it was a stone, I would say, oh, did the gallbladder connect to the small bowel, forming a fistula that led to the stone, then obstructing the small bowel, leading to small bowel obstruction? If they told me that, that mass, you know, I'm trying to think what else it can be. I wouldn't think a fecalith looks that good and sound. And I wouldn't, like a fecalith can obstruct the appendix, maybe a diverticulum, but to obstruct the whole bowel doesn't make sense to me. Like, so yeah, I don't know. I'm not sure what that is. Is it a stone? If it is a stone, then a good plausible answer would be a gallstone ileus. Because remember, a stone shouldn't be enough to obstruct the intestines if it's traveling its normal route through the cystic duct, because it's so small. The only way it can cause actual obstruction is if the gallbladder connects with the bowel, the small bowel, and then there's actually erosion from the gallbladder into the small intestines. I'll pass the mic to you, Robbie, and just for my own space learning, remember Travis presented us a case of the gallstone that obstructed the pylorus. What was that syndrome called? The eponym?
Bouveret syndrome.
Thank you. Bouveret. I always forget it. But is that, what do you think that image was?
Yeah, no, I have nothing to add, Prof. I think you nailed it. Yeah, I think that if you ask yourself, how does air get into the biliary tree? When you have pneumobilia, unless you have gas-forming organisms, you have to have a connection between the biliary tree and the intestine. And the connection is usually something that gastroenterologists do because they do a sphincterotomy. They break the sphincter. But a spontaneous pneumobilia is a vesicular, sorry, I'm thinking of something else, is a gallbladder. There's a term for it, colo something, but the fistula, like you said. And so I love that. I love that. I didn't realize how powerful your teaching was about the size of the stone, because you're right, a stone that big will never make it out of the cystic duct. And so, and I think the location at the ileocecal valve is also very telling, because the ileocecal valve narrows is a place where these stone can catch. So yeah, I would worry that this patient has a fistula, like you said. And it just, you know, when I'm sitting here, Prof. Rez, is I'm just like amazed that this patient must have had chronic subacute or chronic cholecystitis, because you don't make a fistula overnight. And so to really emphasize, the one thing I neglected to emphasize in the history was her neuropathy, and the fact that she had such advanced diabetes that she doesn't feel anything. And that really, I think, influences the calculus for today, because I think if we're on the right track, Prof. Rez, we're hypothesizing that she had gangrenous cholecystitis, eroded her gallbladder wall so much so that she made a fistula, and that she comes in with this complication. And look at her white count, look at her temperature, unbelievable. So you just have to be very, very vigilant to pretty serious infections or infectious processes in patients with diabetes with normal white count. Yeah, very, very humbling. I'm right there with you, Prof. Rez.
Dude, thank you so much for making the connection to like the diabetes and how you can get this really catastrophic inflammatory visceral process and not even come to clinical attention. That's such a good connection. And yeah.
Humbling, right? Very, very humbling. Yeah, Manahel, what did you all find?
Okay, so the picture I showed to you guys was of a gallstone. Patient was diagnosed with small bowel obstruction due to large gallstone obstructing the ileocecal valve. And that gallstone was successfully removed and patient improved post-operatively with supportive care.
Incredible case. I know, Manahel, you didn't get to take care of the patient, but I'm curious, when you were putting the case together, what were you thinking? What were your reflections?
Yeah, like I was more towards like altered mental status, some neurologic causes, but when I reached to that, it was a great surprise for me that I learned that small stones like passes easily without causing the obstructions, but large stones become impacted, and especially if they impacted ileocecal valve, it become difficult to pass through there due to the narrow lumen and less active peristalsis compared to the rest of the small intestine. And one more thing I learned that if a patient is presenting with like nausea, vomiting, distension, and you find the imaging of pneumobilia, small bowel dilatation, and a transition point, so it is like most likely suggestive of gallstone ileus. I think you're mute, Ravi.
Oh, so sorry. I was just gonna thank you. It's not easy to tell the story of a patient you did not see, and I think the ability to do so without compromising the narrative, and in fact to set us up for a really good conversation. And I also enjoyed that you didn't tweak the story to make it less neurologic. Initially, you were very true to the fact that this patient had a really bad neurological syndrome, but it was very interesting to me to make note of the fact that you gave us confusion CTA right up front. And that is a marker of somebody who's constructing a presentation very well, to know that that's not going to be the focus of our conversation. So that was absolutely awesome. Thank you so much, Manahel, for putting it together. I'll just take a second to tell you that all of you at some point in your lives will be enriched by reading about the causes of small bowel obstruction. And then after you've read about it, to read about causes of small bowel obstruction in patients who don't have prior surgery. Because surgery-related bowel adhesions are over 70 to 80% of causes of bowel obstruction. And so when you remove small bowel obstruction without surgery, and then you say there's no hernia, and patients with hernias account for 20% of bowel obstructions, you're now dealing with the rare of the rare, the 10% of small bowel obstructions. And so if you represent this problem after the imaging of a small bowel obstruction without hernia, without prior surgery, the hypothesis of gallstone rises even before you note the pneumobilia and do the laparotomy. So I encourage all of you to read about that space. It's a very, very important one to have. But Rahul, let me hand the mic to you for your teaching points.
Thank you so much, Minahal, for breaking this case. Personally, I only read the gallstone ileus in the textbook for the steps, but this is the first time I'm seeing this case. Thank you so much. And thank you so much, Rabi and Reza, for the incredible discussion. And I really want to share some beautiful pearls today that Rabi and Reza shared. The case started with hyperglycemia and with altered mental status. Even sometimes with hyperglycemia itself, it can cause a cellular shift and could result in cerebral edema, but it could be from other way around. Let's say the patient got admitted with any other history and is not eating well and not taking insulin, and insulin, because of the not taking insulin, it can develop into hyperglycemia. It could be from a casual direct association, or it could be an underlying factor which is driving both altered mental status and hyperglycemia. And the next presentation was the patient has some difficulty speaking, and Ravi really mentioned two important things here: the difference between aphasia versus dysarthria. Aphasia is a language problem. Let's say the patient has any difficulty comprehension or difficulty, the motor function. But the dysarthria is like a production problem, as an issue with the bulbar muscles or pharynx or vocal cords. This is the differentiation between the aphasia and dysarthria. And because of the ongoing confusion and not able to speak properly, and with a given medication list, and Ravi really demonstrated a really, really key pearl here, like medications travel from head to toe. So it could cause any kind of diffuse manifestation. Likewise in anemia, where most of the patients will have chronic fatigue. And Reza really, and there was in the vitals, there was a tachypnea with normal saturation. In what condition we see that? It could be seen in acidosis or in anxiety or any kind of pain. It's important in this situation to rule out respiratory tract obstruction. And as the case was progressing, the patient is having a diffuse distended abdomen. And how can we achieve progress in this space? It's better to visualize the anatomy. What are the structures that are present diffusely in the abdomen? Is it bowel wall? Is it bowel and vascular structures, and then nervous tissue? In this situation, bowel would be high in the high differentials because of the given labs, and it could be from obstruction linked to the perforation, or it could be ischemia leading to the other manifestations. In this situation, it's really important to rule out or examine pelvic exam to look for any inguinal, femoral, and obturator hernias, because all these things could really cause a bowel obstruction too. And also, and getting the CAT scan of the abdomen would be really helpful in the situation to rule out obstruction versus perforation. And coming to the labs, there was a high ongoing hyponatremia in this patient with a given hyperglycemia. It could be because of the cellular shifts, and also maybe because patient is drinking a lot of water, or it could be from osmotic diuresis. And we cannot really completely rely on this hyponatremia, because once we correct the underlying glucose, the sodium will be get corrected. And in the situation of how can we start giving fluids in this patient, it's not advisable to give a lot of NS, because NS has sodium and chloride of 150s that could really inhibit the tubular feedback and versus the AKI. So it'd be better to not give too much of NS, and also it causes non-normal anaerobic metabolic acidosis. So in this given situation, ringer lactate is the most preferred IV fluid. And the possibility of osmotic demyelination syndrome is that there are new studies coming up that Rabih shared. It is not due to because of the rapid correction of sodium. And in the setting of AKI, it could be from pre-renal versus intrinsic, and post-renal in the female patient is less likely. And Reza shared important point regarding metformin in a hospitalized patient. We can hold metformin in patients presenting with AKI. And with the ongoing ketosis and elevated lactic acid, it could be from starvation ketosis because the patient is not eating anything. And even lactic acidemia in this patient could be result from a type A lactic acidosis, and it could be from metformin induced or any ischemia. And if with a given ongoing AKI, raise the creatinine, and whether we have to go with the CT angiogram or not. But if our pretest probability is high, it's better to go with the CT abdomen and CT abdomen with contrast, because the benefit is much more than the risk itself. And you have to, for this patient, and by the time he goes to the radiology lab, it's better to continue the ringer lactate and give some insulin to shut down the ketosis. And there is other 3+369 rule to look for an evidence of bowel obstruction. And these are the normal caliber for the bowel. If it's less than 3 centimeters for small bowel, less than 6 centimeters for large bowel, and less than 9 centimeters for the cecum. And Rabih shared what exactly is air fluid levels. Because of the lack of peristaltic wave, the fluid gets stuck to there rather than just getting reabsorbed, and that could visualized on the imaging. And adenemic ileus would be high possibility too, but in this situation, it's better to look for bowel wall, any contrast enhancement, or any presence of air in the bowel wall itself. And lastly, the presence of pneumobilia. Like, is there any, it means presence of air in the biliary tract. Is it because of the gas producing organisms, or from if abnormal fistulous tract connecting the bowel to the biliary system, called as colobiliary fistula? And lastly, looking at the causes of small bowel obstruction, 70% of the bowel obstruction could be from adhesions because of previous surgery, and 20% from the inguinal hernias, or it could be any hernias, and 10% would be a rare situation like in this patient, gallstone ileus. Yeah, that's all I have. Thank you so much.
Rahul, I don't think we need to hit record anymore. We just need you to be here, and you will automatically record everything. That was absolutely outstanding. Really, really nice job. I also appreciate you adding diameters for each segment of the valve. That was very, very helpful.
Thank
All
you,
right.
Ravi.
Hope you have a wonderful rest of your day. Prof. Rez wishes you all a great time from his ongoing hard work at the VA. And that was for you, Prof. Rez. See you all later. Bye.